again to Race Academy webinar series. Number 15. Who could believe we're at number 15? It goes to show you how long we've been down, but coming to you from Sydney in lockdown. So apologies about the mask. I hope I can be heard well. So today, another fantastic topic, and to see we've come a long way running these webinar series. My grandfather, who started this business in 1936, probably has no idea what a webinar is. And we've come all the way today to streaming across the globe with undoubtedly Australia's most knowledgeable professor. So I'd like to welcome everyone across the globe from 8, 9, nearly 10 countries now, with well over 170 odd people registered for today's program. Temporomandibular disorder. Where does Splints fit in? So again, last week's response to our our Splint webinar has been overwhelming. So again, we've asked Professor Michael Stubbs to join us in how to treat temporomandibular disorder and where splints actually fit in addressing the needs and the requirements of each patient, and if splints can help, which ones to use when and how. So with no further ado, I do ask you to send your questions in as we go, and we'll be hitting up Professor Stubbs at the end of the program to address these questions. But with no further ado, I'd like to hand it over to you, Michael, please.
Thank you, Matt. As always, it's a real pleasure to be part of the Race Dental group, and thank you for inviting me to speak. Temporomandibular disorders, or now I'm going to say the term TMD, really refers to a condition which is musculoskeletal pain involving the joints and the muscles themselves. And in 70% of cases, it's both. In about 15% of cases, it can just be the joint only, which I'll talk about. And obviously 15% of cases, it's just the muscles. We would say myogenous pain. And we recognise too that it's a collection of terms. So when we say someone's got TMD, what we're really saying is they've got a number of symptoms. You know, it might be muscle or joint pain, sure. They might have reduced jaw mobility. So as a consequence of the jaw pain, they can't physically open or close the mouth, or they may have mechanical changes in the joint, which is also restricting the ability for them to open or close the mouth. They may experience headaches, tinnitus sometimes, maybe 1 in 10, which I'll talk about. And, of course, the symptoms of jaw stiffness or fatigue, tiredness, particularly when they're chewing. And so there are several pain condition or presentations that can manifest itself, what we call TMD. But what is interesting is there are very much common underlying mechanisms, which I'm also going to talk about. And this is the reason why different treatments work for different patients. And it also, in my view, helps explain why sometimes you make your patient a splint, and even though you've done the best splint you can and you've sent them to a special physio, some patients still have problems, they don't respond. Now, please move this window. I'm really sorry. I don't know quite. That happened last time as well. I'm sorry if you can bear with me on that. So let's revisit anatomy first, just briefly. We know that the temporomandibular joint consists of the condylar head. You've got the cartilage here. Now, in cases where you get osteoarthritis, that's where you get the degeneration of the cartilage surface. This is the disc, and it looks actually like a donut or a figure 8 configuration in cross-section. That's the fossa, and that's the eminence. So when the patient opens their mouth, as you all know, the disc and the condyle in an ideal situation with the lateral pterygoid muscles inserted in the condyle pull down the eminence to about here. And this tissue here, the bilaminar or posterior zone, is elastic, stretches, and then when the patient closes, the whole mechanism comes back to the normal position that we would deem as normal here. But of course, we know that joints don't always have to be normal, as in appearances, but also more importantly, as we get older or through trauma in the jaw joint structure region, you can get structural changes. And I've put in here, sometimes patients' chief complaints might be just noisy joints. So clicking, cracking of the jaw when they open or close the mouth. Some people, we use the term crepitus, which is like an eggshell crackling sound. That's more in keeping with osteoarthritic change, where you have the loss of the smooth surface of the cartilage on the condyle. It's very rough and irregular, and it sounds literally like eggshells crackling. And closed lock is a term where you can see, for example, in this situation where the disc is actually sitting completely forward. So like the image I showed you earlier, in the closed mouth position, here's the condyle, here's the fossa, and hey, look, that disc is sitting forward, not between the condyle and the fossa region as we would deem as an ideal situation. So clinically, we can sometimes make these judgment calls based on how the patient presents. I mean, fortunately, the term disc displacement is a term which means, as you can imagine, the disc is sitting usually anterior. And we use terms like with reduction and without reduction. What that really means is that in this situation, these are disc displacements without reduction. So in other words, as the patient opens their mouth, the disc remains, in this case here, forward. It doesn't reconnect. And so we call that disc displacement without reduction. Closed lock, in my opinion, is a stupid term, but that's what they call it. It just means that basically the patient can't open their mouth. An open lock is pretty rare. It's where the disc sits behind the condyle, and so the condyle sits forward and the patient literally can't close their mouth and the teeth are separated, posterior teeth are separated. And osteoarthritic change, I mean, here you can see on the top right-hand side, quite a flat, irregular condyle, and that's obviously, in this case, certainly osteoarthritic change. The assumption often is that patients have to be really old to have osteoarthritis. No, they don't. It's physiological, it's non-inflammatory. One thing I would strongly advocate, just imagine this was your patient and you're looking at a cone beam here, and let's say you see flattening here and loss of bone there, same patient. It's always a good idea to get them referred off for an MRI, because sometimes you can get tumours in the joint or cysts, but particularly tumours. You just want to make sure if you take a radiograph and you see something unilaterally like that, one side, and the other condyle looks normal, it is fair to say at least a CAT scan or an MRI would be most appropriate just to rule out disease. But we know that some of the clinical features associated with TMD are a little bit like I presented when I talked about bruxism. Typically, the headaches present what we say is frontotemporal. Classically, it can be around the eyes or behind the eyes as well, and it's estimated to occur in about a third of patients. And the International Headache Society recognises that secondary headaches can be attributed to TMJ. So what that really means is primary headache might be migraine. Migraine has very classic presentation. Patients get orbital pain, nausea, pounding, have to go into a dark room. Whereas this type of pain, musculoskeletal pain, they might have pain across the forehead. It could actually be aggravated or worsened by somebody having TMD. And it doesn't mean to say that just because someone has pain in the face, jaw, or any part of the body, it's caused by one thing. And that's an important thing to remember. And that's what makes our job challenging, actually, because we always like to link a cause for a problem. But sometimes a problem can have two or three causes. The only way you work them out is you always treat the obvious, and once you've eliminated that variable, you start to work through a process of deduction to ultimately eliminate symptoms. We know that we say it's mild to moderate pain. Now, I use that term cautiously because what's painful to you might not be painful to somebody else. But in fairness, someone who's got TMD, they'll often talk about like a mechanical pressure or an aching quality pain, which is aggravated when they move their jaw, opening, closing, clenching their teeth. But more importantly, it's not something that someone's going to come in and say to you, it's the worst pain I've ever had. My God, I've got this headache. It's come out of nowhere. They're the kind of cases that you would start to think maybe I should send them off for a CT scan or emergency department. Because, you know, again, for most people who have TMD, it's a very, and it can be severe, it can vary in intensity. But when you get those patients that come with absolute severe pain, you start to think maybe it's not TMD, maybe it's trigeminal neuralgia, and they're for future talks to discuss with you. You typically get pain in the front of the ear, hence the term preauricular. But again, sometimes patients, if you ask them, like I always do, describe your symptoms. They'll often talk about pain down the face, masseter, into the neck, sternocleidomastoid, up into the temporalis. Now, sometimes some patients say, where's the pain? Everywhere. So if you get pain on both sides of the face, always think musculoskeletal as your first sinusitis, but think musculoskeletal also as a possibility. Pain can be generated or aggravated if you've got inflammatory change in the joints. But of course, the way we understand TMD is this pain condition is where you're getting sensitized changes in the nerve endings of the soft tissues. And so when patients can talk about pain when they push here, 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 and logic tells you that that's not all inflammation. And so the important thing to remember is that patients who talk about pain, always ask them how they feel, what they can describe in their own words first before you start even examining the patient. Again, we know pain on clenching or moving the mandible. So if someone's got pain and you're thinking, is it tooth pain? And you say to somebody, if you yawn, does it hurt? Or do you move your jaw, it hurts? And they say yes, you can start to think again, is it musculoskeletal pain? We also understand that when we measure mouth opening and movement of the jaw, you can use that as a guide. So if someone says to you, for example, I can hardly open my mouth, and you measure it like you can see in this photograph on the left-hand side of the screen, and they score 60 millimetre opening, you know that they're actually pretty much way above the normal range. On the other hand, if someone can only open 12 millimetres, which is what I just had about 15 minutes ago, then you know clearly you're starting to think, is there a disc displacement? Is there a mechanical locking in the joint? Shifting the mandible side to side, it should normally be about 8 to 12 millimetres. Again, you can measure this. These are useful things to do and record. Once you start treatment with your patient, these are things that you can remeasure on consecutive appointments. So yes, you might say to the patient, how are you feeling? But you can also get some idea yourself about how, in fact, they are improving by comparing to your previous notes. We also realise pushing in the joint is an obvious, isn't it? Pushing in the TMJ region, patients will often elicit pain. But the trick is push in the posterior pole aspect. So in other words, behind the condyle, and particularly if they open their mouth and you push in there, you'll actually elicit the pain. Sometimes you can put your small finger in the ear canal, and if you palpate into the ear canal distally at the back of the joint, you might elicit pain response as well. There is no connection between the ear and the joint structurally. The reason the connection is it comes back to this desensitization or nerve ending sensitization where the brain always defers to the larger structure. So someone who's got, say, TMJ pain often may present chief complaint, just headache, or they may actually come in and say they've got earache or blocked ear on a chronic basis. With the ear symptoms, the thing you always ask your patient is, has the doctor looked in the ear? And if they say yes, and they couldn't find anything unusual, push in front of the ear, check the temporomandibular, because that's usually the culprit. And that's an interesting thing, this slide here, but you can see how the blocked ears, people have hearing tests and they're told that in fact their hearing's normal, but again, it's attributed to the temporomandibular disorder. And the reason for that is the brain, again, in processing information, defers to the ear. So you get these disturbances in feelings. Sometimes patients talk about like things wiggling around their ear, like water, or they feel like their ear's blocked or full. They can't hear themselves talk. And as I said earlier, we understand that we're talking about generally muscle and joint involvement in most cases. And it's usually a dull aching quality and often presents in both sides of the face. Sometimes if you have a patient who'll come in and say, I've got pain here, and then when you examine them, you might be surprised to note clinically they're sore on the opposite side. That's not unusual. It does happen. It's about how the mind interprets the pain experience. And lastly, when we're talking about symptoms, always consider those cases, where you get those posterior molars that are aching or causing pain. You've eliminated a cracked cusp, you've ruled out caries, you've eliminated any pulpal causes or periodontal causes. Palpate the masseter muscle. If you get illicit pain on palpation, consider the possibility it's referral of pain into the tooth-bearing area. One way you can very easily make that judgment if you're not 100% sure, prescribe them some diazepam, 5 milligrams, and at night for about 3 to 5 nights. You'll very quickly find out how much of the pain is caused by referral of the masseter muscle. So when we talk about the incidence of TMD, it's estimated, as you can see here, about 3.6 to 7% of the population. I'd go as far as to say about 1 in 10, actually, or 10%. And there's no single cause for it. So we understand that some form of trauma, whether it be microtrauma, such as clenching or grinding of the teeth, might actually aggravate or initiate the symptoms. We don't say that people that Brux develop TMD, but certainly it's a big aggravating factor, hence the value of a splint. But also, blows to the jaw, a motor vehicle accident. If you get a patient, let's say, who's had a car accident and they've had whiplash injury, I don't mind saying to you, 6 to 12 months after that motor vehicle accident, they'll start to develop TMD symptoms. It's quite an interesting observation, but it does seem to be a common experience. And certainly also other factors. They might have rheumatoid arthritis. They may have other types of conditions. They might have depression or anxiety in some cases, where there's an increase in bruxism, an increase in pain, discomfort, and experience of that pain and discomfort. So it can be from different origins. And the OPERA study was a very famous publication, and it was a study it's called Orofacial Pain Prospective Evaluation Risk Assessment, or OPERA for short. And the value of this, which I'm just briefly summarising, is that they looked at prospective cases. So that means in the US, there were 3 major multi-centres that had enrolled patients, 3,258 adults to be exact. None of them had TMD symptoms at the time of the enrolment. And the reason they did this was they followed them up. Now, at the moment, they're still doing that. So, we're talking 14 years down the track. But the benefit of this study was that it showed that there were 72 patients of that large group that developed TMD and the symptoms resolved, and 75 patients developed TMD and the symptoms did not. Question: why was 75 and 72 developed out of all those numbers? So what was some of the risk factors that caused that? And it helps our understanding of the problem, because we use this terminology, which I won't go on laboriously, but it's actually irrelevant. Central sensitization. It just means that when we talk about pain, whether it be muscle, joint, or both, we are dealing in patients who often have the symptoms for months or years. And this is a chronic neuropathic pain condition. And that's why making just a splint for some people works brilliantly. And sometimes they need physio and a splint, and other people need physio, a splint, and Botox, or physio, splint, Botox, and medication. And it's because of those variabilities in the management. It doesn't mean your diagnosis is wrong. It just helps explain why some people do well with some treatments and not others. It's also interesting to note that the current views are there's no genes that we have that predict your likelihood of having TMD onset, but certainly there seems to be a genetic factors relevant to people that get persistent or ongoing TMD pain symptoms. And we also understand that, people say, people that with TMD, are they anxious? Is that why they have the problem? Well, not everybody who has depression or anxiety has TMD, but also we understand that these conditions can influence pain behaviour. They influence bruxism, which is the clenching or grinding of the teeth. And it can be a factor in the way the patient presents themselves. Now, interestingly, from this study, which it showed also there was a high correlation with people that had chronic TMD and those that had lower back pain and genital pain. So, folks, you can ask the question if you wish about lower back pain. I don't know if I'd ask the patient about genital pain, but the thing is, it's something that they showed an association. I think the take home for this is that sometimes people that have chronic TMD may have other chronic pain type syndromes. And this rather interesting slide is just being put up by me because when we talk about pain, it's not just mechanical. And I think that's the important take home. As dentists, we understand very well about engineering, biological engineering. That's what we are. We're biological engineers. We understand science and we also appreciate art. But the reality is, in this context, we have to understand that there are other things as well, how someone is experiencing the symptoms, what other effects they might have in their life currently happening at the time, and the various neuropathic conditions combined together is how that patient presents to you when they're sitting in the chair. And so we call that the biopsychosocial model. And the reason I'm touching on this is just for completeness sake, so that when I start talking about devices, I just want the take home to be that they are very useful splints to help patients, but there are often other treatments that might be required because pain is an experience. And so when you get injury, whether it be to your face or you got pain in the joint, pain in the muscles, or both, sometimes there might be other underlying things that you're not privy to. For instance, you don't know what the person's like at home. They might be going through a lot of pressure or stress at work. They may have had previous chronic pain issues that they have never had resolved, etc., etc. And this is just some of the terminology that sometimes patients present with. And I put these in too because they're important. So if I say to someone, how do you feel? And they say things like, my lower jaw is not aligned properly. My ear aches all the time, but my doctor told me it's normal. You write those down, because when you start to follow your patients up over time, you can always come back to what they told you. And you say to the patient, does your lower jaw still feel not aligned properly? And they might say, well, yeah, no, it feels good. Or does your ear still ache? Well, no, it's resolved. Because sometimes people forget. And when they come in after a course of treatment, they might come in and say to you, I've just paid a lot of money for this splint. I've seen a physio. I'm not getting any better. And it happens. People say it because they forget. They re-establish themselves almost like they forget what they were like when they first met you. So that's why it's important to write down some of the way they describe their symptoms, because to that person it means a lot. I mean, if someone says to me, my bite is out of whack, that's not really a proper diagnostic term, but to that person that means a lot. Hence, I would say to that patient in follow-ups, does your bite still feel like it's out of whack? It's very sensible. I know it's very basic, but very important. So when we talk about treatment, the reason we talked earlier about this neuropathic element and the fact that it is not just a straightforward process is that in any pain condition, some treatments work brilliantly for some, and other people, as I said earlier, need lots of inputs, whether it be from a psychiatrist or a psychologist, pain management clinic. Obviously, as dentists, we would help a lot too with what we can do, such as making occlusal splints. But also, more importantly, it might be involving physio. You may need to have other inputs. If someone comes in pain, they might need to see an endodontist, or an oromax surgeon or an ear, nose and throat surgeon. So it can be multidisciplinary, and that's an important thing always to remember. And we understand too, this Cochrane analysis is one, or meta-analysis it's called, is always something that they review multiple papers, thousands actually, and then they deduce the studies based on well-designed studies, and then statistically they draw conclusions out of it. And I think the important thing here is that the Cochrane meta-analysis says if you have someone with TMD and you do nothing, they will eventually get better. Now, that might be a reality based on statistics, but I think it's fair to say at an individual level, how long does that take? I mean, I've had patients who have had symptoms on and off for 30 years. So the point is, yes, statistically, you could argue, does splints do much? Does physio do much? But in reality, if you've got someone in pain, it's very appropriate to think about some evidence-based approaches that you can do to help treat them. So the basic principles, number one, rule out organic disease. Take an x-ray of the jaw joint. You don't need radiographs or a CAT scan or a cone beam to make a diagnosis of TMD. What you're using it for is to rule out the possibility of a tumour. Does the patient have osteoarthritis? Does the patient have rheumatoid arthritis? Maybe that's why the joint's inflamed. Counselling doesn't mean teaching them to make them feel better. It's looking at daytime things. Ask the patients, do you bite into fruit? You should chop them up. Do you eat food with height? Break it up into smaller pieces. Do you chew gum? Never underestimate the fact that people chew gum. They think it helps the jaw because it makes it work harder. And as you know, it makes it worse. And also recognising things that aggravate or irritate the problem. So if someone says to me, for example, I wake up every morning, my jaw is stiff or sore, it's fair to conclude there's bruxism happening. If someone says to me, look, I wake up feeling good, it's just the end of the day, I've got all this facial pain and jaw pain, daytime strategies is going to be your first step. And that's where you might entertain the idea of seeing a special physio for your patient in the initial round of treatment options that you discuss. And the American Association for Dental Research, this was a benchmark paper published 2010. And the reason I put this up is it's a guideline that I follow, and I would strongly advise anybody else who treats people with TMD have a good understanding of. You don't need fancy EMG treatments, in my view, to make a diagnosis of TMD. We base it on clinical history, clinical presentation. And we also recognise the value of imaging and the value of some medical-based tests, such as checking for inflammation markers in someone who's got rheumatoid arthritis, And your treatment should always be conservative and certainly evidence-based as much as possible. That's the structure that we work in. That's the framework that we have to work in as dentists, and we do in most of the things that we do. And there's no specific one treatment for everybody, but we understand that doing invasive treatments is not necessarily your appropriate approach, in my view. I do not see the value in doing multiple onlays on a patient to help their temporomandibular disorder. Science does not support that. And also it's very important too that you teach them things that they can do themselves, such as looking at what they eat, how they chew, yawning, show them some simple stretching exercises. The Roccabato technique, published 21 years ago, is a good benchmark paper that you should have a look at. And so, again, we know that whatever treatment we do, ultimately people get better. But when someone doesn't get better, it's not necessarily a failure of what you've done or haven't done. It's recognising that some patients need more inputs than what we can do just as dentists. And those patients that often never get better, there's usually, in my experience, something else underlying driving the process. So we understand, obviously, from our own experience, OPG is a great source of evaluating both the jaws, the teeth, and also getting an idea of the condylar heads. We also understand the transcranial views are great because you actually get a 3D perspective. If you go from the condyle, looking at it from the frontal region and then the side region, it just gives you a little bit more information. They're simplistic, but they're very useful forms of evaluating the mechanism. Cone beam, if you're lucky enough to have one in your practice, are superb because they obviously show, in this case here, you can see on the right-hand side, there's an osteophyte. You can see in the middle image, quite thin, it's got osteoarthritic changes. We would call these bony cysts. It just simply means degeneration of the bone. And so with splints, the basic principles, in my view, would be always have a complete arch. Now, people say to me, is a maxillary splint better than a mandibular? No, they're both as good as each other. The reason I use a maxillary splint is just from my own experience of making lots of mandibular ones. Patients bite their cheeks. When you make a maxillary one, you tend to get the benefit of holding the cheeks out of the way when the patient is actually bruxing. It's also important to make sure that they're even. So when you do make a splint for your patient, you should really check them every 6 or 12 months when you do the review visits with the patient's general dental health. So don't fall for the trap of holding the splint up and going, oh, yeah, that looks all right. Some articulating paper in there. Get them to do a few moves. Trim even it up. Give it a polish. If you're lucky enough to have a polishing wheel, some pumice. They have to be smooth. They work more efficiently. A lot of patients I see will come in with a splint they've had for 5 years, never been adjusted. And they do get uneven. And if they get uneven, they become less effective. You'll see I've written here, adjusted to centric occlusion. Now, some of you watching this would be saying, no way, you've got to do centric relation. My thinking is that centric occlusion, because the splint is flat-planed, the benefit of having that means you have opportunity for the mandible to move in any position it wants to. So therefore, the idea of having a defined occlusal record, as in setting the splint in centric relation, you might feel better about doing that. But in reality, you'll find that when you fit the device, you can often make any minor adjustments. And certainly when the patient comes back for their review visits, not everybody bruxes the way you might imagine them to. So yes, a patient's sitting up in the chair or lying slightly back. You put your articulating paper in, they start to move their jaw laterally and protrusively. But in the reality, when they brux at night, they may not even do any of that in those particular estimated positions. So the trick is make sure you have a flat plane splint so that it allows for variation of movement. And now, again, other people say to me, well, how much thickness would you have of your splint? What's the interocclusal distance? I think it's interesting because 3 millimetre is probably the average. I mean, this paper published here in 2008, now it was 2008, doesn't discount the value of the paper, but it said they found that 3 millimetre increase in vertical dimension was superior to 6 millimetres. Well, I have to tell you, if I get a patient who comes and sees me with a flat plane splint, and they're usually very well made, and our patient says to me, I'm wearing that device, but I'm waking up in the morning, my jaw is still stiff or sore, that tells me it's not doing enough. We understand that splints don't stop bruxism. what they do is they reduce the power that you can generate. And my view is it's actually because of stretching the masseter muscles and taking out some of the power or strength. So the thing I do is I add acrylic posterior blocks, which I'll show you a design of a splint in a moment. And the idea of that is biologically you are stretching more the teeth apart, you're stretching the masseter muscle, but you're not creating a ginormous, if such a word exists in English, splint, which is like the Great Wall of China. It's too big to wear. So flat plane splints, folks, I realise that's a pretty much a given. I think they're really good. I love the milled ones. I love the keystone ones that Race use and make. And more importantly too, there is sometimes a question about, do orthodontic retainers, do they aggravate clenching or bruxism? The answer is they don't. And I put this in there because they show that, in fact, sometimes some patients will say, well, I've got 2 retainers, I don't need a splint. Well, that's fine. But one of the things I'd say to you is the retainers are usually 1 millimetre thick. And again, if you can get something, even if you have a patient post-orthodontics, where they might have a lower retainer, the upper one, if you need a splint, you'd aim for 3 millimetres and they can wear the lower retainer opposing the upper splint. You still get the stability of the dentition, but you'll also get more benefit in regards to the symptoms of the waking in the morning with a stiff or sore jaw. This is a girl splint. Some of you watching this may actually use them. I don't. But again, the reason I don't is because in this situation, the anterior teeth, mandibular and maxillary, don't contact. Now, we do concern ourselves, don't we, about over-eruption of teeth. And so one of the things is having both the anterior teeth, maxillary and mandibular not contacting, the possibility of over-eruption, I would think, is greater. Again, whatever you're comfortable using. The idea of this is to disengage posterior anterior contact. And again, it's displacing the space between the posterior aspects of the dental arches to create the same effect that, in my view, we'd do if we had a full upper arch and posterior blocks. Now, this is one example of a full arch splint, but you can see the design here. It's actually thinner here and slightly thicker here. These are the posterior blocks I'm describing. So I usually would design one where I go from 7 to 4 in the situation. In this case, 1/4 to 1/7. And you can see anteriorly the space. Now, some of you, again, watching this is going to say, hang on a minute, what about these lower ones? They can over-erupt. Really interesting. We don't tend to see that very often at all. However, I can't say it won't happen, but the aim of the game is, again, looking at the left side, the aim of the game is to reduce the power, but also recognising that sometimes patients need more height than 3 millimetres interocclusal distance. The anterior repositioning splint, some of you watching this might make these as well. It's an interesting area. I don't use these devices. I don't like them. And the reason I don't like them is several reasons. One is that, in my view, the motivation behind an anterior repositioning splint is to pull the mandible forward and influence the positioning of the condyle on the disc. So if the disc is sitting forward, anterior disc displacement with reduction, when you pull the condyle forward, the thinking is that the patient wears this device, such as this, in the mouth, and in reality, it's pulling the condyle forward, trying to influence the position of the disc relative to the condyle. It showed, and I'll just go back to this particular paper, they showed, in fact, that even though the patients in MRI studies before the anterior repositioning splint was fitted, and then 6 months after, they found 40% of patients actually had the disc improved in the relationship of the condyle. It's not a long-term management. The disc ultimately comes back forward again. And the problem I have with this concept is, in reality, patients pay for a device that's going to last them, 3 months, 6 months? What do you do if you get an occlusal open bite? Posteriorly, you're going to do onlays, crowns, orthodontics, and that's where I think you don't need to do that. And in my view, I would be going much more for a conservative flat plane splint, or as I just said earlier, the ones with the posterior blocks, at least, to help reduce the efficacy of the bruxism and how it's impacting on the muscular pain in the morning, and more importantly, trying to be as conservative as you can so you don't create other problems. So we know that the advantages of an occlusal splint, we understand they protect the teeth. I mean, that's a given, isn't it? But in reality too, it shows that in fact they do change patient behaviour. So what does that really mean? Well, there is a hypothesis that sometimes the physicality of having the splint at night, intuitively the patient has a behaviour where they tend to keep their teeth a little bit apart during the day. Now, that is a hypothesis, but it's a reasonable one. It also means that the patient ultimately can choose when to wear the splint. It's not a punishment. They don't have to wear it for life. Only 10% of people you'll find often will wear it every night for the rest of their life. Most people, 90% after 6 to 12 months, will often cease using the device, and we encourage them to use the splints just when you need them. So if someone says, right, they've got a bit of jaw pain, they're having a bit of a stressful day, they might say, right, I better wear that splint tonight because I bet you I'm going to work my jaw hard, I'm going to wake up with jaw pain. And so that's the benefit of educating your patient in strategies they can do during the daytime, recommending a jaw exercise routine or seeing a special physio for the jaw, and using the splint. The patient in the end treats themselves, and that's the ultimate advantage in this approach. And so the limitations is some people will tell you, oh, well, when I actually wear the splint, I clench a lot more. Well, yeah, that's true. But I think it's because intuitively sometimes it's a foreign body, isn't it? And patients naturally bite. My advice to a patient is I'll say, yes, but when you're clamping on the splint, you are generating less power than what you would be if you had your natural teeth clamping together. And the possibility of occlusal changes is a reality. And as I said to you, the ones I showed you, particularly the full upper arch with the posterior blocks, I can't say you won't get any tooth movement with the lower incisors in that model case. But the reality is we don't seem to see that very often. But it can happen. And that's where the benefit of following your patients up comes in. So if I see a patient and I fit a splint, what I'll do is I'll review that patient usually 8 weeks after I fit it. Then I might see them again in about 3 to 4 months. And it depends on how much symptoms they're experiencing. If they're getting better, and a lot do, then I might see them just once a year, ultimately. Or in your case, you might do it as part of your normal review visits for your patients as part of their dental examination. But certainly I do not recommend patients wearing splints 24/7. I don't understand the logic in it. I know people argue mechanically it helps reduce the discomfort and the positioning in the condyle relative to the fossa. Again, that's where the thinking comes in. You're treating a condition that's not just a mechanical issue. It is a pain condition where, yeah, there's mechanical issues such as disc displacement, there may be pain in the muscles, but again, it comes back to it's not just mechanical. And so the idea of having, in my view, someone wearing a splint 24/7, I would never advocate that at all, because you end up creating what I would deem as a dental cripple, somebody that gets to the point where they cannot function. They can't function without pain if they take their splint out during the daytime. Now, again, everyone watching this, you have your own ideas, and I appreciate and respect that. But from my point of view, that's something I would never recommend. And again, you know, as I said earlier, make sure you do adjust your splints and at a regular interval. And most people, you would wear a device every, say, 6 to 12 months, and then gradually you wean them off it. Some people feel more comfortable wearing it at night. That's fine, they can. But again, it comes back to recognising you've got to make sure you just check them to make sure they're nice and smooth. And I don't recommend soft ones, folks. Those flexible ones, I think in my career, and I mean, I'm not the expert, but I've probably only made about 8 of them in 19 years now, because it's like chewing gum. Patients, you know, just chew and flex on it. So my advice is you always go for the hard acrylic. The ones that I've made are those that didn't tolerate. So again, you know, we're dealing with human beings here. What we deem as ideal doesn't always fit every patient. And that's where experience comes in. And Botox, I just put this in for a bit of fun, really, because Botox is something that is done for some patients. I mean, my advice to you is, you know, I get referrals from colleagues where they've done Botox first. And I think to myself, well, why didn't you do a splint? You know, why didn't you talk about some physio or something? So Botox is a useful treatment. The jury's out really on how effective it is. It doesn't stop bruxism either, neither does a splint. But when you think about it, this will last about 3 months. It takes 2 weeks to start to work. And then, you know, the cost might be $700 or $800 a treatment. And a patient might have 3 treatments in 12 months, sometimes 4. The reality is if you make them a device, at least it's conservative and I think more cost effective. But again, Botox has its place, and it's picking the patient. And the last thing to talk about is exactly what I just said. There is potential evidence for usefulness of Botox, and I'm not discounting it, but it's certainly not my first line therapy. Thank you.
Yeah,
Any questions?
Yeah, Michael, we do have a couple here. I'll just jump straight off the edge. I've got one from Neil and Nath saying, I often use the anterior repositioning splint in a centric occlusion position as an airway-friendly splint, with many people finding their sleep is also improved. May I have your thoughts on this?
Yeah, look, I understand why you do that. The thinking is two things. One is the concept also is that by pulling the mandible forward with the anterior splint, you're actually not just keeping the airway open, but you're supposedly helping with bruxism. I would only use one of those type of devices if I had a patient that actually was diagnosed with sleep apnea. So I'd do a sleep study first. And secondly, again, it's what you're comfortable using, something I don't use. I don't think you need to, but again, it's what you're comfortable working with.
Okay, last week, Michael, last week you spoke about mandibular advancement splints.
Yep.
Can they cause TMD over time? And if so, how do you treat this?
Yeah, they don't necessarily over time, but usually you'll find most cases get the TMD symptoms, if they're going to, in the first 6 weeks. And so my advice is it's all about position of advancement. So just imagine someone comes along and they've had a mandibular advancement splint, they've been wearing it for 6 months, and then suddenly they get TMD symptoms. You might then look at it and say, right, well, firstly, you might look at other therapies. You'd maintain the splint because obviously it's got a role to play with their apnea. Presumably, it might just be snoring. But if it's apnea, I'd definitely be getting them onto a physio. And I'd also be suggesting in the short term that perhaps the use of anti-inflammatories if they need them, and certainly the possibility of Norflex. Now, I mentioned Norflex in one of the previous talks. It's called orphenadrite, which is actually an antihistamine, and that's a beauty because it's non-addictive, and they can take it at night. Yes, it relaxes the muscle tone, makes the mandibular advancement splints work slightly harder, but they're useful tools. My first go-to always is before I say to the patient, right, you've got to have a break from wearing your mandibular advancement splint, I'd definitely get them to a special physio for their jaw first.
Okay, should we always do a transcranial radiograph to assess TMD?
Good question. Look, I do. Just to share with you, the academia, you don't need imaging necessarily to make the diagnosis of TMD, as you know. But I do it because it's simplistic. It's effective in the sense that you get a screen or visualization of the condyles 3D. And I think as simple views go, I think it's useful.
Okay, we've just got one coming from Dr. Mouthé saying, what about daytime bruxing?
Yeah. Well, daytime bruxing, there's a couple of things, isn't there? I mean, one of them is we know that anxious people certainly represent 40% of bruxism during the day. And so what I do is I think about things like either anxiety reducing conditions or treatments such as seeing a psychologist. Now, I know some of you might say, oh, yeah, that's all right for you, you're a specialist, but that's one thing. And the other thing is too, there's a very simple Roccabato technique, which I recommend, and it's where the tip of the tongue sits on the nasopalatine papilla, and then you open the mouth, hold, count to 20 and relax. And so sometimes if patients have an awareness that their teeth are engaging, just this simple stretch and relax is actually a very simplistic way of helping. I have had patients in the past, let's say they're at work. A lot of people at the moment in a lot of our country are working at home because of COVID lockdowns. You can wear your splint a few hours during the day. I'm not against the concept. And some people are focusing on the computers. They might intuitively be clenching. You could certainly recommend that. But I do not advocate 24/7 use of devices.
Okay, we appreciate that. With regards to the splint with posterior blocks, why leave a space anteriorly and why not contact all around the arch?
Yeah, I know it's a good question, and the answer is bulkiness. It reduces the bulkiness. So you get the efficacy of what you're trying to achieve posteriorly, but you don't have an enormously bulky device and then expect your patient to sleep with it.
Okay. Well, we've got some more pouring in here. I'm going to have to vent a few here. Do you have a preference in where to use a flat plane versus Michigan canine guided splint?
Yeah, good question. And I failed to put an image of a Michigan, so thank you for raising that one. Michigan splint's terrific. There's no reason. I mean, to me, that's a flat plane split, but unlike the posterior block guidance, you're actually using the anterior ramp 3 to 3. And so when the patient slides laterally, you're opening up the vertical dimension. So you're quite right in highlighting that. A Michigan splint is as good as, in my view, a flat plane splint.
Okay. Look, Michael, there's still some coming in, but we have reached the end of our time frame. I've got our crew here waving at me in the background. Is there anything you'd like to mention? Is there anything you'd like to finish on, Michael, just to wrap us up? We've got a lot of people with questions. If we could pick your brain with one last thing to go away with, maybe that might help.
Yes. I think the thing is, for what it's worth, in the first 5 minutes, if you ask the right questions, you get the diagnosis really quick. And so remember, always ask a patient when you are examining them before you even look at them. Always ask them, do they have any ear symptoms? Do they experience headaches? Do they experience fatigue or pain in the jaw when they're chewing? Do they wake in the morning with stiffness or soreness associated with the jaw? Because those simple questions give you guidance as to A, the probability that the pain they're presenting is TMD, and B, the likelihood of the value of a splint. If you've got a patient who's got a significant muscular pain cause, splints work well.
Okay, look, that's a fantastic piece of advice. Using your ears is twice as much as your mouth. My father always said that's something we should look at doing through life, and it's a good piece of advice. Michael Stubbs is contactable at drmichaelstubbs@hotmail.com. His webpage, www.michaelstubbs.com.au. If there's any further information you do need from us at racedental.com.au, feel free to contact customer support at any time. Customer support at racedental.com.au. Michael, we thank you. I do have one piece of late mail that's just come in. Ginormous, mate, is a non-standard word, but it does appear in the Oxford Dictionary. So even your informal language is perfect.
Thank you very much.
Well, on that note, thank you all. Race Academy webinar series. We hope to see you again next month. Keep safe, keep smiling from Sydney.
Thank you. Thank you. Bye.